Good morning, everybody. Thank you, Dipti, for the introduction and for a lot of new information on the genetic basis. So now my task is to take you through a little bit to the clinical challenges and unmet needs in the daily routine and in the management of patients with diagnosis. And this is more part of the following two speakers of the following speakers, also to talk then about treatment. So we have heard already about KIT and additional somatic mutations. And I want to take you through this again. So these are really the two main genetic characteristics of the disease. So number one, KIT. KIT can be present only in mast cells, but KIT can also be present in other hematologic lineages. So, for example, in leukocytes, in monocytes, in eosinophils. And as long as the KIT mutation is only in the mast cells, this is basically systemic mastocytosis. But whenever the KIT mutation is also in other lineages, this gives rise, for example, to monocytosis, leukocytosis, and when the disease progresses, even in myeloid blasts. And that was seen by pathologists 40 years ago when they saw these biopsies. They saw mast cells on one side and CMML on the other side. And therefore, they called the disease at that time SM with associated whatever they saw. CMML or MDS or MDS-MPN. I mean, it sounds complicated, but the genetic basis is at the first level that KIT can be present in mast cells or also in other myeloid lineages. And then, about 10 years ago, following all the work on additional somatic mutations, and here I really have to say Alessandro has done, for example, fantastic work, and his group with Paolo Guglielmelli on myelofibrosis. And there was other work done on CMML. And then we and others looked into the genetic profile of advanced systemic mastocytosis. And we were very surprised that we basically found more or less the same mutations in 70–80% of patients. I mean, we usually know SRSF2 from CMML, we know AS6L1 from myelofibrosis, RUNX1 also from AML. So a very similar mutation profile. And we also found that the number of mutations counts very similar to the other diseases. So basically, the additional somatic mutations produce the clonality of the disease. And then on top of that, we have KIT as a phenotype mutation. And when I have Alessandro sitting next to me, I would say myelofibrosis and mastocytosis are basically, from the genetic basis, very similar. We have more or less in many of these patients who are multi-mutated, the same profile of additional somatic mutations. And on top of that, we have phenotype mutations. So we have KIT on one side that makes mastocytosis, and CHEK2 on the other side, which causes then myeloproliferative neoplasm. But it is even more complicated. So the problem is now patient number A. This is simple. He has a high mast cell burden, he or she has a high mast cell burden, a high tryptase, and a high monocyte count, and we find KIT D816V at a high level in peripheral blood. Then we can assume, because mast cells are usually not in the blood, that the monocytes are positive for KIT D816V, and that this is, let me say, a typical SM-CMML. But in many of these patients, the mast cell infiltration is quite low, maybe only 5 to 10%. And this is frequently overseen. A, because hematologists may not even do a bone marrow biopsy, and the pathologist does not know about the mast cells. And he sees a full bone marrow with monocytes, with eosinophils. And if the pathologist does not think about mastocytosis, and if he does not perform immunohistochemistry with tryptase and CD117, he may miss the disease. So now in patient number B, for example, we have low mast cell burden, low tryptase, but again a high monocyte count, And then, surprisingly, we find a high allele burden in peripheral blood. This is also SM-AHN. But in this case, the KIT D816V allele burden is higher in the AHN. And this may be, the most dramatic disease in this scenario is, of course, AML. So you may have an SM-AML with only 5% mast cell infiltration, but, 80% blast, of course. And on the right side now, we have the scenario with the additional somatic mutations. So very similar to patient B, but now the KIT allele burden is low. And you may be irritated when you see that, what is this constellation? And then you do the additional somatic mutations. And then you may find SRSF2 as a level of 40%. These are also a considerable number of patients. Have low KIT in blood, but high SF2. And again, this can also be the case in SM-AML. And this is the basis of what we say when you look in the clinical routine in your patient. You have to decide which compartment is basically the dominant. Is it systemic mastocytosis or is it the AHN? But at the end of the day, you not only need bone marrow biopsy, bone marrow mast cell infiltration, serum tryptase, you always should know KIT D816V allele burden, best in blood and marrow, and also the additional somatic mutations with their allele burden. This is probably more important, or is more important than in many other hematologic neoplasms, because you may really see a difference in the allele burden between blood and bone marrow. So, and this is now the clinical scenario. And you know about the C findings. C finding means advanced disease. It's like stage 3, stage 4 in lymphoma. So it means malabsorption, weight loss, ascites, low albumin, thrombocytopenia, anemia. So this is really, this all looks like advanced CMML or advanced myelofibrosis. But in addition, patients may have massive ascites. They are more sick than patients with advanced other related diseases. And on the right side, you can see that they are not only the C findings. So patients have abdominal lymphadenopathy, they have splenomegaly, they have GI infiltration, sometimes cobblestone GI infiltration. In many of these patients, misdiagnosis as eosinophilic colitis, because the pathologist also did not think about potential presence of mastocytosis. But in the meantime, alkaline phosphatase elevated, because it is so frequent, and splenomegaly, of course, have been switched from what you can see here as additional characteristics also to being C findings. So very important. And what does it mean in the daily routine? In fact, we identified 30 to 40% of our patients with advanced systemic mastocytosis from other patients. So cohort number 1, the patients who have been diagnosed with CMML or with myelofibrosis. So a routine NGS testing, but KIT is not included. Nowadays, in the more modern NGS, it is now included. And sometimes, only with the second or third biopsy or with the peripheral blood, sometimes comes around the KIT D816V mutation. And then you go back to your pathologist, and he may say, oh yes, there was mastocytosis, but I didn't know about KIT, so I did not find it. So we identify about 20% of patients in previously diagnosed whatever chronic myeloid neoplasm, particularly MDS, MPN, and CMML. But we also diagnose mastocytosis in AHN in patients who were previously diagnosed, let me say, as indolent systemic mastocytosis by the pathologists. And then there are always, some hints to that. So we would recommend, in fact, for every patient with a chronic myeloid neoplasm to perform tryptase in serum. This is very cheap. And of course, to also include KIT D816V molecular testing in an NGS, or to do it by PCR, because you would miss a disease, as you will see in the following talks, which has targeted treatment and complete remission. So, The other problem is, I already talked now about the tryptase. The tryptase is very nice if it is elevated. If it is elevated, it is usually systemic mastocytosis. There are sometimes, it is also found in other myeloid neoplasms, but you have to think about mastocytosis if it is elevated. The problem is the tryptase is not elevated in all subtypes of systemic mastocytosis. I am personally aware not of a single patient with advanced systemic mastocytosis with a normal tryptase, but in indolent disease, patients may have a normal tryptase. So the C-finding framework is also not always so easy. I mean, is a hemoglobin of 10.3, is it, cytopenia already, low platelets? I mean, you have to think about mastocytosis in the whole picture, particularly if a patient has monocytosis and if a patient has eosinophilia and monocytosis. And then you have the mast cell, in addition to the mast cell burden, you have the symptoms. But please, you must be aware, you must take that home from today. Advanced systemic mastocytosis is not the disease with anaphylaxis and flush. So this is the disease, this is indolent systemic mastocytosis because it is mast cells. Advanced systemic mastocytosis, it's a stem cell disease. This is a hematologic neoplasm. And many patients with advanced systemic mastocytosis have no flush, no anaphylaxis, and no osteoporosis because, in fact, they have osteosclerosis. So advanced systemic mastocytosis is, in fact, a hematologic stem cell neoplasm. And now you may really see this, it is really a clinical, very heterogeneous disease and also genetically a very heterogeneous disease. And then, of course, the symptoms. So, of course, patients with advanced systemic mastocytosis also have urticaria pigmentosa. They still have symptoms. I mean, when I said, anaphylaxis and flush is rare, but of course, they may exist, and there may also be all these neuropsychiatric symptoms, the musculoskeletal symptoms, the pain. Almost every patient with systemic mastocytosis, whatever, has some sort of joint and muscle pain. And then, for advanced SM, it is really the important issue is organomegaly and organ failure due to infiltration. And this is now also very important. What Dipti said, it is not only the mast cells, but also the AHN that causes the organ failure. And then, and what I said about the differences between indolent and advanced disease and about the symptoms, you may see that the symptom burden of patients does not correlate with the mast cell burden. You may have a patient with indolent disease, low mast cell burden, but very active, causing a lot of symptoms. The patient with advanced disease may have a high mast cell burden, but not that same type of symptoms. But overall, of course, like in many other diseases, and probably more than in many other diseases, the symptom burden really impacts very much on quality of life of the patients. So advanced SM management, so it is really a multidisciplinary action. So for many patients, when I said, portal hypertension, ascites, I think for advanced disease, one of the most important partner in the management of your patient is the gastroenterologist. We have several patients who needed a TIPS because of portal hypertension, in addition to active targeted treatment. But on the other side, the approach should always be individual. So you need a continuous reassessment of the patient, really by specialists and also the pathologists, the gastroenterologists. I mean, the pathologist, of course, is also a very important person, for diagnosing and quantification of the disease. And then, I mean, this is all very complex, and I think that you really need to, this patient needs to be seen at a center who really has good pathologists and good multidisciplinary management of the patient. And I want to talk a little bit about treatment. I mean, now you heard a lot about, the different subtypes and the basis of the different subtypes, that it may be really a pure mast cell disease, what we now call pure mast cell disease, or it may be SM-AHN. And this is just a very short overview. Alessandro will go into that in much more detail, that you may in fact also see heterogeneous response in the different subtypes to drugs like midostaurin or avapritinib, whether it is advanced, whether it is aggressive systemic mastocytosis, which is a more pure mast cell disease, whether it is SM, AHN, or whether it is MCL. And as my final slide, I just want to show you how difficult it makes this genetic scenario for the individual patient. Here you can see a patient who was diagnosed with KIT D816V at high allele burden and with several other additional mutations, in this case SRSF2 IDH1. We shortly treated the patient with midostaurin. We switched the treatment to avapritinib. The patient achieved complete remission on mast cell infiltration, tryptase, KIT D816V. However, the additional somatic mutations remained, so there was no response, of course. We thought allogeneic stem cell transplantation may be a good idea. We did that. All the mutations disappeared, all the additional somatic mutations. The patients remained in complete remission, but then what you can see, he had a relapse, and the relapse was while he was after allogeneic stem cell transplantation, and the relapse was while he was still in complete remission of mastocytosis, and it was, unfortunately, relapse and death only caused by progression of the AHN caused by additional somatic mutations. So these are my key learnings, and maybe I just leave it as it is, and when we talk about it, you can read through this. So thank you very much.